Okay, so we have discussed the how we should use the fluid. The fluid should be but preferred crystalline fluid and later colloid fluid. If the patient is losing blood, then blood is the best replacement. But initial we should not give the blood because usually that blood is cold, is kept in the blood bank, so it is closed and containing some uh, potassium. So that if cold blood you can give that any patients, that may cause the coagulopathy. So that one thing is there that cause the triangle of that death, that is hypothermia, bleeding and coagulopathy. We will discuss that is separate topic in separate topic. We discuss that things. So to avoid and that due to that having this uh, potassium, that may causes the little myocardial depressions. That's why initial blood should be avoided. Once a patient is get a little bit settled, then we can give the blood. Initially, crystallite solution are best. Just you can give any patient. Ringer's lactate is the best solution. You can give any patient if you are suspecting any kind of a shock. Okay, so next come to the drugs. Which drugs we should use in the shock patients. So especially in the traumatic shock, when the patient having severe pain, in that cases some little bit sedation may be required. So in that case you can give the morphine and barbiturates in the childs, and in adults morphine can be used. But there are a few contraindications if patient have the head injury. So in that case morphine should not be given to that patients. Some other painkiller may be used. Then chronotropic agents, these should be used in the case of that the cardiogenic shock, when the cardiac suppression is there, bradycardia is there, heart rate is very low. In that case, the atropine may be given. Inotropic agents are given also in the cardiogenic shock to increase the heart rate and to control that heart rate. So that dopamine is the drug which should be given in the, especially in the cardiogenic shock, especially because these inotropic agents give strength to that cardiogenic our cardiac muscles. So if muscles are not contracting properly, so by giving this dopamine, you can increase the function of this cardiac muscles, so that increase the cardiac output. Then vasodilators are also used in cardiogenic shock and some condition of the traumatic or septic shock. When patients, when the card, especially the carotid arteries is not properly acting, means heart is not getting proper blood. So in that case, that this vasodilators may be used, that nitroglycerin, nitroprusside, that may be used. So these due to acting this causing the vasodilation, so that the proper circulation is given to the heart, and heart is so that it increases the heart rate, and the blood pressure also increases. But the very important thing is that these vasodilators should be used in these all these drugs. You cannot all these drugs in general. These all this conotropic, inotropic, vasodilator, vasoconstrictor, beta blockers, and diuretics also. These are very important drugs, and these should be used under the always used under the in ICU condition, intensive care conditions, and you must have the very good knowledge of these drugs. If you don't have the knowledge of these drugs, you should not use drugs. Rely only on the fluid therapy. You have to use drug in only conditions when you are not able to maintain that you're not able to resuscitate patient with the fluid therapy, and you must have very good knowledge of to use how much dose you should, because very calculative dose should be given. Just like in the nitroglycerin, it should be given very slowly, because if you give in the large dose, high dose, then it causes the vasodilation, and vasodilation may increase the shock conditions, and patients that may cause the distributive shock condition. So in order to correct the cardiogenic shock, you may give the distributive shock to that patient. That's why I'm saying these drugs, you not the all always second choice. These are never first choice in the management of the shock. You must have the very good knowledge of how to use what dose. You must be very clear. If any doubt, do not use these drugs. Similarly, the vasoconstrictor drugs may be required sometime in the neurogenic shock condition, when due to this the neurogenic conditions, that their vasodilation is happening in peripheral vasodilation. So if you give these drugs, it can increase the vascular resistance in the periphery and increase the blood pressure, so that increase the that cardiac preload and afterloads. Similarly, the beta blockers, these are purely used in the cardiogenic shock. If that patient have the cardiogenic shock and the myocardiac and myocardium becomes stiff and heart rate increases, so in that cases the beta blockers have the good effect and increase the ventricular contractions and increase the increase the cardiac output, and try to correct this hypoxic condition, shock conditions. Diuretics are also used in the cardiogenic conditions when there is a high blood pressure. Patients may have severe blood pressure more than 210, systolic maybe 200 and more. So in that conditions, these diuretics are to be used to decrease the blood pressures. So first thing, the drugs are never the first line therapy in the management of the shock. First line therapy should be fluid. If a fluid is not, you are not able to control the fluid either, you must know that this is a particular condition where this drug can help. Just like in the cardiogenic shock, if you know that, and you, if you know the very well the dosage system of the medicine and all that, only this that condition you give the these drugs, otherwise just rely only the medicines, only fluid, sorry. Then monitoring, how you have to monitor your patient. So there is a so many things you have to monitor, but the minimal requirement of the monitoring is heart functioning of the heart, that is ECG, pulse oximeter to give the oxygen saturations, blood pressure, as well as the urine output. These four are the minimum requirement. Four things have you have to monitor minimally to control the shock conditions. In addition, you can have the central venous pressure, invasive blood pressure, cardiac output, bed deficit, and serum lactate. But these are not uh, essential. But these four things: ECG, pulse oximeter, blood pressure, and urine output are very essential to manage the monitor to manage the shock conditions. You must have to measure, monitor these few things to know the patient is transit or responders, no responders, that things. Then the end point. What is the end point of resuscitations? You know how to when to start. Everybody knows, if you suspect a patient of a shock, you start resuscitation. Then second thing is how when you have to stop the resuscitations. So traditionally, when the patient is well oriented, having normal pulse rate, having normal blood pressure and good urine output, then you have to stop the resuscitations. But there are few guidelines. Sometimes patients may maintain these things, but patient may not have proper recovered from the shock. So that the end point of these have given that base deficit and lactate, mixed venous oxygen saturations through blood. So these things are considered as the end points. But traditionally, if the patient is well oriented, normal blood pressure, normal urine output, normal heart rate, then you can stop the resuscitation process. So that's how we have finished this complete shock condition, shock management of the shock. Thank you.